So, thank you for your patience. I hope many of you were able to grab some food for this lunchtime symposium entitled Recent Breakthroughs for Hormone Receptor Positive, HER2 Negative Early Breast Cancer Patients. Since many of us have contributed to the development of some of these fascinating, innovative prognosis and predictive tools that should help us to better tailor the individual adjuvant therapy, I think it's absolutely worthwhile to discuss for the next hour accurate risk management and local testing using the Prosigna test. And I'm very happy to say that, in fact, while you know probably the pivotal studies that have been undertaken in several places around the world, there have been recently very interesting data, not only on the prognostic performance of the test in different clinical risk groups, but there is also now scientific comparison between some of these tests, which I think are interesting to discuss, and obviously a growing body of real-world evidence and data outside clinical trials. And what we'll try to do in the next 60 minutes is to dissect for you what is the actual value of the test, particularly with the property of accurately defining the so-called intrinsic subtype in your and our clinical practice. In order to save some of the time, because the previous session overran significantly, I have already asked our wonderful faculty to come up here. And without further ado, we will start with the first presentation by Dr. Eva Ciruelos from Madrid. She doesn't need too much introduction. She's a medical oncologist. She has been the president of SALTI, and she's going to speak to us about moving to precision medicine, clinical utility of molecular subtypes in breast cancer. Thanks, Eva, for being here.
Thank you, Dr. Nant, for your kind presentation and the organizers for inviting me to review the clinical utility of molecular subtypes on breast cancer. So these are my disclosures. So Prosigna assay has been tested since, by now, 20 years ago, and have been approved for its use in Europe and in the US around 6 years ago. For its use in the HR-positive postmenopausal patients with early luminal type disease to take decisions on the adjuvant treatment, such as is a value prognostic factor for these patients. So this assay has a main difference with other genomic assays or other biomarker analysis that we could apply in the breast cancer setting. And that is that this assay is able to subclassify breast cancer into different molecular subtypes. So these intrinsic subtypes are not recapitulated by immunohistochemistry, are not recapitulated by other assays that test a lesser number of genes. So we need at least 50 genes to have this intrinsic subtype classification, basal-like HER2-enriched luminal A, luminal B, that have a very different prognosis as well. So this information is really important for us, and these intrinsic subtypes are represented into every type of phenotypic classification. We see that this heterogeneity is high. All subtypes are included in the luminal phenotype. They are included as well in the HER2-positive disease, and they are included in the triple-negative disease. So we cannot subclassify breast cancer based on immunohistochemistry, as immunohistochemistry, as Pepe Viale said yesterday, is just based on expression of one protein, which is ER positivity, or overexpression of other protein, which is HER2 overexpression. So biology is much more complicated, and we are able to dissect breast cancer through this genomic analysis. Are we able to use maybe more routinely used biomarkers such as Ki-67 regarding the division into luminal A and luminal B subtypes? The answer is no. Ki-67, regardless on the cutoff point that we can use, is not able to reproduce the classification into luminal A and luminal B as Prosigna score does. So the rates of discordances are around 30%, which is too high. So maybe because of reproducibility, lab problems or lab issues, Ki-67 is not ready to do that. Regarding adjuvant setting, we do know that Prosigna score is useful in selecting patients who would need adjuvant chemotherapy or who wouldn't, because these patients are subclassified into low, intermediate, and high risk groups based on Prosigna score from 0 to 100. This score is based on the integration of the molecular subtype identified by PAM50, by a proliferation of score, genes related with proliferation mainly, and it includes as well clinical features such as tumor size and node positive. Inclusion of these clinical features is a really good idea as prediction value, especially for late recurrences, is much better, is much higher in the platforms that include clinical factors into the algorithm, into the score. So Prosigna is useful as a prognostic tool to determine the evolution of patients who not need chemotherapy in the node negative and in the node positive as well. This has been tested in the registration trials and in the Danish trial that will be covered by the next speaker. And regarding the classification into luminal A and luminal B, these two groups have a very different prognosis as well. So as we can see here in this pooled analysis of over 2,400 patients, we can see that the prognosis for luminal A's is much better than luminal B's, either in the node negative and in the node positive as well. If we focus on which is the probability of being a luminal A, I have a low, intermediate, or high recurrence of a score. We can see here that luminal A's are in general low or intermediate ROR, and luminal B's, or maybe other non-luminal subtypes, in general are intermediate and high ROR. So this is the gray zone that is called intermediate risk that could be represented either by luminal A's and by luminal B's. So I think this is important for us to better implement the utility of the subclassification of these intermediate risk patients into luminal A's and luminal B's to take adjuvant decisions. If we review again results of the Danish trial, I won't focus anymore on this trial because it will be reviewed in the next talk, we can see again that luminal A and luminal B are different prognosis populations. So these patients behave so differently and maybe should be used to take decisions, especially when ROR is not so clear because it's included in that gray zone which is called as intermediate risk. Regarding the adjuvant setting, nice data from Dr. Pratt's lab in which we can confirm that intrinsic subtype is clearly correlated with the probability of getting a PCR when we use neoadjuvant chemotherapy. Over 800 people treated with neoadjuvant chemotherapy, and we can see that the major probability of getting a PCR is seen just in luminal B's, HER2-enriched, and basal-like patients. These are data from 180 patients in which ROR score is also correlated with the probability of getting a PCR, so it demonstrates that ROR and intrinsic subtype is clearly related with sensitivity to chemotherapy, at least in the neoadjuvant setting. It's been demonstrated in the adjuvant setting in the two top trials shown in the table, and also in the neoadjuvant setting as well. There are subgroups, luminal Bs, HER2-enriched and basal-likes, that would benefit much more from neoadjuvant chemotherapy than luminal As. That is why in our group, SALTI group, we have developed this nice trial. Last results will be ready at the end of this year for San Antonio meeting, in which we have compared the efficacy of chemotherapy versus letrozole plus ribociclib. But we have selected postmenopausal luminal phenotype patients who harbor luminal B intrinsic subtype. Such it would not have been so logical to include in this trial luminal A patients who would not be benefited from neither from chemotherapy, neither from new combinations with CDK4/6 inhibitors. These are data from the HER2-positive disease as well. This is a nice and wide analysis on 13 neoadjuvant trials that test again that intrinsic subtype is really important for the prediction of having a PCR after receiving neoadjuvant chemotherapy plus anti-HER2 targeted therapies. All these trials have shown that having a HER2 intrinsic subtype is a good prognosis and good predictive factor for achieving a PCR. The differences between PCR got in the HER2-enriched versus non-HER2-enriched are so clear and so consistent among these 13 trials. I will briefly review metastatic disease. This is not a talk on metastatic disease. This is preliminary data that should be demonstrated in prospective trials. So just to open our minds on maybe future perspectives on the utility of intrinsic subtype also in the metastatic disease as well. The first problem could be that intrinsic subtype is not exactly reproduced when we measure that biomarker in the primary tumors versus metastatic samples. So we can see some discordances, mainly in the luminal A patients. Some of them, 15% of them, become more aggressive intrinsic subtypes, such as HER2-enriched. Despite that, we have reviewed results in terms of prognosis based on intrinsic subtype and classification of patients who've been treated in 2 big phase 3 clinical trials. First of them is 008 trial, in which first-line patients were treated with letrozole plus or minus lapatinib. Second one is Bolero 2 trial, second-line setting, exemestane plus or minus everolimus. Regardless on treatment received, we can see that the top curves, the blue ones, that represents luminal A and luminal B tumors have a much better prognosis than the other intrinsic subtypes, HER2-enriched and basal-like. And this is seen despite 80% of samples analyzed in these trials proceed from primary tumors. So even when discordances have been seen, this is a strong prognostic factor also for the metastatic disease. In the more recent trial, Paloma 2 trial, you well know about Paloma 2. Some analysis has been done and presented 2 years ago by Dr. Finn in San Antonio meeting, in which they represent here the 20% of patients who have a HER2 intrinsic subtype, patients who have luminal type breast cancer and who be treated in the Paloma 2 trial. First of all, you can see that median progression-free survival times in that HER2-enriched subtype are shorter. So this could be the meaning of they are a worse prognosis. And the second thing is that the differences between median progression-free survival between patients treated with letrozole and patients treated with letrozole plus palbociclib are nearly known. So there's a less benefit of the addition of palbo when we're talking in that context of HER2-enriched subtype and when compared with luminal subtypes in which the benefit of palbociclib is so clear. So what to do in this HER2-enriched subtype? Maybe endocrine treatment or CDK4/6 inhibitors are not the best option, but there are still some other options to be tested. One hypothesis is being generated from this retrospective analysis on the 008 trial by Dr. Pratt, and he showed that the addition of lapatinib to letrozole could be beneficial just in the HER2-enriched subtype. This hypothesis will be tested in a second SALTI trial called NEREA trial, in which we will test the efficacy of an anti-HER2 targeted therapy, in this case neratinib, in combination with endocrine treatment in this luminal phenotype HER2-enriched subtype. And not just anti-HER2 targeted therapies, but checkpoint inhibitor therapies that could be of value in combination with chemotherapy also for these patients. Just to show you the last example of the importance of intrinsic subtype in the metastatic setting is the intrinsic luminal subtype into the HER2-positive disease. We've just seen the Dr. Weiner's talk, and we see that heterogeneity into the HER2-positive disease, especially into the HER2-positive, ER-positive disease is high. We have around 50% of that patients that harbor HER2-enriched subtype. The other 50% harbor intrinsic luminal subtypes. So if luminal subtype is not a good predictive factor for achieving a PCR with neoadjuvant chemotherapy or with neoadjuvant plus anti-HER2 targeted therapies, could be an option as well, or an opportunity to test new drugs, maybe not based on chemotherapy for these patients. These are the first results of the PATRICIA trial, led by SALTI group as well, in which patients with HER2-positive, ER-positive disease in the third, fourth, and fifth line setting after trastuzumab and a taxane therapy were treated with palbociclib plus trastuzumab, with or without letrozole. All patients received the same treatment, so the differences between blue bars and the dark ones are differences in intrinsic subtypes. You can see that in the blue curves, luminal A and luminal B intrinsic subtype is represented, and they have a much better prognosis with median PFS over 12 months when compared with non-luminals, in whom median PFS were less than 4 months. So achieving a median PFS over 12 months in third, fourth, fifth line setting in the HER2-positive disease is really great. And that's why we are exploring this combination, palbo plus trastu versus best decision's choice based on chemotherapy treatment in patients who have been pretreated with at least one prior line. And this will be called PATRICIA 2 trial in that randomized design. So to take home some messages, I would say that subtype cannot be recapitulated by immunohistochemistry, neither by other platforms that uses less number of genes. PAM50 score can help to identify patients with luminal phenotype disease who don't need chemotherapy. This is level 1 evidence and has been approved by all agencies, and it's commercial, and we are ready to its use. Subtypes could predict chemosensitivity in the luminal phenotype in the early setting, not just in the adjuvant setting, but in the neoadjuvant setting as well. And this is really important tool to take correct decisions when we have a luminal patient and we are not sure that she needs chemotherapy, and we have to take the decision between neoadjuvant and adjuvant treatment, which is a really common clinical situation. Subtypes can predict prognosis as well in the luminal phenotype in the metastatic disease. These are retrospective data. We have to test them prospectively. Subtypes predict anti-HER2-based therapy sensitivity in the HER2-positive disease, and we have very nice data in the Neo-Adjuvant setting. We should be ready to, for example, de-escalate treatments from the Neo-Adjuvant setting depending on intrinsic subtype, or de-escalate chemotherapy as well, depending on intrinsic subtype in the advanced disease. So this is a unique opportunity for our patients. And finally, future prospective trials should establish the real clinical utility of intrinsic subtype in all these early and advanced different settings. Thanks very much.
Thanks a lot, Eva. We have time for a couple of questions to the speaker. Maybe while people are still considering, in your clinical practice, how do you manage intermediate risk patients?
That's a marvelous question. As it seems like when you have a really complicated patients in terms of decision making, you are waiting for your genetic test to help. And sometimes you get into the intermediate risk. So, especially from the combined analysis and from the Danish trial, I do use intrinsic subtype for the decision-making process. So, into the intermediate risk, I would recommend adjuvant chemotherapy in luminal B intrinsic subtype, and I would not recommend any chemo in the luminal A. And that's my routine practice by now.
Well, but that's essentially the question why you do it, okay? So this, I think, is very helpful. And how do you integrate the classical clinical factors into the algorithm? Oh, yes,
Prosigna does. And I think that's of value. There's a recent editorial published in JCO by Nick Turner and Mitch Dowsett last week or a couple of weeks ago, and they have the same analysis. Why not to include all the information that we have, including clinical factors, for the better decision making for our patients? And I have the reflection that the two genomic assays, which are Prosigna and EndoPredict, that includes clinical factors into the algorithm, are the only two platforms that can predict late recurrences. So I think this is of value, and this has to be done. And we shouldn't avoid information that is really useful for us for the decision making.
Okay. If there are no further questions, thank you very much, Eva.
Thank you, Michael.
Thank you.